Hello, good evening. This is Farah Douglas. I am CEO and President of the Liver Health Foundation. Welcome and thank you for joining us this evening. Our webinar tonight is dedicated to two very important liver diseases: non-alcoholic fatty liver disease, commonly known as NAFLD, and its more advanced form, NASH. There are over 22 million people in the US who are living with NAFLD, and 8 million of them have NASH. We will learn tonight about these two diseases, how we can protect our liver from them, and how we can live a happy liver life. Please note that tonight's presentation is not a substitute for consultation with your own hepatologist. Now a word about Liver Health Foundation. We are a California-based 501c3 entity. Our mission is to provide updated and accurate liver health information to community through free webinars such as tonight's program. To see the complete list of our programs, please visit our website, liverhealthfoundations.org. I want to thank Dr. Tanya Mitsinikos for being the host and MC of the webinar tonight, Dr. Al-Khoury and Dr. Nuruddin for accepting to be our speakers. It is important to mention that our host and our presenters are volunteering their time, talent, and expertise to help liver patients. We thank our physicians for their support. Liver Health Foundation is also appreciative of Excelex's generosity for sponsoring this webinar. At this point, I'll pause and will ask David Schmal, Senior Oncology Account Manager at Excelexis, to say a few words about his company. David?
Well, thank you, Farah. I appreciate the warm welcome and introduction here. As Farah mentioned, everybody, my name is Dave Schmal with Excelexis, and just very excited to join the meeting and support these educational efforts. So just to jump in and describe a little bit about the company I work for, Excelexis. Excelexis is an oncology-focused biotechnology company that strives to accelerate the discovery, development, and commercialization of new medicines for difficult-to-treat cancers. More specifically, and somewhat related to the information being presented here, but still a little bit different, but liver-related. Cabometyx is the product that we promote, and it is indicated in hepatocellular carcinoma. So really excited to be able to support you guys, and have been looking forward to listening to the presentations and learning myself. So thank you.
Thank you, David. Thank you very much. We also need to thank Merck. This program has been made possible in part by a grant from Merck. It is now my distinct, I apologize for my voice breaking. I have been battling a cold. It is my distinct honor to introduce our distinguished MC, Dr. Tanya Mitsinikos, Director, Fatty Liver Disease Clinic, attending physician, faculty member in the Division of Gastroenterology, Hepatology, and Nutrition at Children's Hospital, Los Angeles. Dr. Mitsinikos is an active member in the Pediatrics Liver Transplant Program, as involved in both pre- and post-liver care. She earned her doctorate at Keck School of Medicine of USC before completing her internship, residency, and fellowship at Children's Hospital, Los Angeles. As the medical director of the Fatty Liver Clinic, she helps coordinate multidisciplinary research and patient care for children and adolescents with obesity-related non-alcoholic fatty liver disease. Thank you, Dr. Mitsinikos, for accepting to MC tonight's webinar. Would you please start the program?
Yes, absolutely. And thank you for the warm welcome and the invitation to host tonight's event. It's a topic near and dear to my heart. So let's get started with our first speaker. I'd like to introduce Dr. Mazen Reddy. the director of the Houston Research Institute and the Houston Liver Institute. He's the founding director of the Fatty Liver Program at Cedars-Sinai Medical Center with a focus on clinical and translational research in non-alcoholic fatty liver disease, NAFLD-NASH, as we'll refer to it tonight. Dr. Nureddin has conducted more than 35 investigational, translational, and clinical studies of novel treatments for NASH. He began his hepatology research during his internal medicine residency at the University of Southern California. Following his residency, he moved to the National Institutes of Health, where he was enrolled in a 3-year hepatology fellowship at the liver disease branch of the National Institute of Diabetes and Digestive and Kidney Disease, which included a combined NIH Duke University Master of Health Science and Clinical Research certification. After his NIH fellowship, Dr. Nureddin finished his gastroenterology fellowship at the University of California, San Diego, where he focused on NAFLD and NASH. Dr. Nureddin returned to the University of Southern California and established their fatty liver program and to continue research on NAFLD-NASH while conducting translational research and clinical trials. Subsequently, he joined Cedars-Sinai in 2015 to establish the Cedars-Sinai Fatty Liver Program. Dr. Nureddin is the chair of the AASLD-NASH Special Interest Education Subcommittee and serves on the editorial board for the journals Clinical Gastroenterology and Hepatology and Gastroenterology. He is funded by the National Cancer Institute. Dr. Nureddin, I'm very excited to hear your presentation, and we're ready to have you take it away.
Thank you. Thank you very much. You're too kind for this introduction. It's an honor to be here and to see many friends, and hopefully many of our nurses and patients, even doctors, are back to see our updates. Let me share my screen. So yeah, I'm currently not in Southern California. I'm in hot Texas. So don't ask me to stand up because we wear shorts here when we do a visual presentation. I'm just kidding. I'm wearing full pants. So chronic liver disease, the next 3 decades. I say, or what it looks like, it's going to be disease that the liver disease is going to be induced by mouth. So we have 2 big problems and 2 epidemics now. The first one is NASH, which is related to increased calorie intake and being associated with other comorbidities such as obesity and type 2 diabetes. And the other one is alcohol, which is also that we self-brought to ourselves. And often, as my friend Dr. Arkouri, he's on this webinar, we say baffled, which is both fatty liver disease, NASH, and alcohol, meaning patient eats a lot and drink a lot. So that's what we're going to deal with in the next decade, or maybe even more. But let me grab your attention to a case that it's still stuck in my brain because it was Christmas time. I was a junior faculty, and I got called in December 2017, and I put the exact date because we were all in a Christmassy mode, and the chocolates box around, and I remember like I was having a happy time before a friend of mine called me from one of LA neighborhood, and he told me, hey, I have this gentleman, George, it's a fake name, 59 years old, Mexican male, who was admitted to my hospital with increased abdominal girth, which makes you think that he's calling you because the patient have ascites, which is a fluid in the abdomen that happens in patients with advanced liver disease. So George had a history of type 2 diabetes for 15 years, had cholesterol problem, dyslipidemia, and this is the caveat, this is the sad one, was told he has fatty liver disease about 10 years ago. I'm not going to go into much details, but he drinks about 10 drinks a week. That makes it 1 every day, or 2 like on week, 1 every day on 2 on weekends. Many people do that. He's married. He has 3 children, and he's a young guy. So what happened with George, and this is his labs for those that like to read labs, he had elevated liver enzymes, but not that much, not that too many eye-catching. except the total bilirubin, which is a sign of advanced liver disease if it's attributed to the liver. Also, he had a low platelet count, which usually started connecting the dots together. George has cirrhosis and advanced liver disease. He was actually in much more trouble with having renal insufficiency, meaning his kidney started getting affected. But then there was ultrasound that was done, and they saw a tumor, and it was 2 centimeters only on ultrasound. And the reason they did ultrasound without contrast studies and all this, because his kidney function. So we do, like, some people don't want to affect the kidneys and do just simple tests. And the 2 centimeter mass, even if it's a cancer, in that small size, we can deal with it. Again, cancer can happen from fatty liver. Then when he came to us, we did ultrasound and we did imaging studies. And unfortunately, we found a liver cancer that went beyond the liver in the portal vein all the way to the heart, actually. Unfortunately, this guy coded on Christmas Eve, his heart started beating abnormally, and he expired. I mean, they rescued him from that, but within a couple of days, he was dead. So I was just shocked, like 59, who was told, you have a problem 10 years ago that didn't tell him what to do. And within 6 days, he's dead because of this devastating disease. Of course, this is the most severe case that you don't see every day, but we see them often. And it makes us sad and make us trying to fight this disease. So non-alcoholic fatty liver disease, how common is it? And look at American Blue. It affects 25% of the general population. Of course, not all of them will have George's fate. Indeed, many of them, they walk around without knowing that they have non-alcoholic fatty liver disease. And the good news is that not the entire 25% of the population have the more advanced form of the liver disease, which we're calling NASH. So what is NAFLD? NAFLD, or the NAFLD without the D, is just fat in the liver. And to get to NASH, you need inflammation on top of the fat. And that's about not the 25%, it's actually subpopulation of that. And over time, people can get scarring, and eventually cirrhosis. The diabetics, I always tell them to pay more attention, because the prevalence is not 25% of the diabetes, it's actually double. It is 50% in type 2 diabetics. And these patients, unfortunately, even have more scarring of the liver if they have type 2 diabetes. So watch out for those, the type 2 diabetics, and always look for the fatty liver in this population. We published one of the first data showing in the bottom in purple that NASH became the leading cause of cirrhosis. And also we showed in another publication we published in 2018, if you look at the left, the leading cause of liver transplantation in male in blue is alcohol, followed by red, which is NASH. And in female, it is NASH followed by alcohol. So NASH in 2018 became the leading cause of liver transplantation in women. I also want to point you to the yellow. Yellow is hepatitis C that used to be the leading cause of transplantation. But because of therapies that were introduced in 2014, we don't see much liver transplantation from hepatitis C anymore. So hopefully we can get to that with NASH as well as fatty liver. This is the projections. Are they scary? In 2015, we have 83 million people with NAFLD. In 2030, we have 100 million people with NAFLD. And with cirrhosis in 2015, we had 1.2 million, extending to 3.1 million in 2030. I don't want to take away also from alcohol. Alcohol, especially a condition called alcoholic hepatitis, especially with COVID, they are on the rise and causing us to have a major number of transplantation in this country as well. So again, the fatty liver has two faces, one alcohol and one non-alcohol. Indeed, it's fatty liver, like George, is the leading cause of liver cancer in NASH patients. It used to be hepatitis C, but now it's NAFLD. I'll skip this. This is what I told you about the disease. You have NAFLD with the fat only. You have inflammation on top of the fat to get to NASH. And luckily, those are not 25% of the population. Those are just subpopulation of the 25%, about 20% of them, but still a lot of people. And this inflammation is kind of gas on fire, leading to scarring here. You see it seen in blue, and at the end of the disease spectrum, you see cirrhosis and cancer. What has been shown recently that these scarring is actually what lead the patients to die. So fibrosis and cirrhosis are the major problem in this disease, which was very important for us because we used to do liver biopsies to figure out if the patient has NASH or not. But since the scarring is the most important one, we realized that we can measure scarring without doing liver biopsy non-invasively. So this is what I want to tell everyone today, that you don't have to go around and poke people to find if they have NASH or scarring or not. We have other tools. And who are at risk? We have to look for the disease on those with type 2 diabetes and metabolic risk factors, and of course, if they have high AST and ALT. And luckily now, multiple societies guidelines told us, like, you start with type 2 diabetes or metabolic syndrome, and you do a simple score that is based on blood tests that can identify these patients. So these data is from the American Gastroenterology Association. These data are from the European Association, and these data are from South America Association, and even from Asia. All of them calling for screening for high-risk population, which is type 2 diabetes or obese patients. Now, why type 2 diabetes and metabolic risk factors? I'll skip this, but basically what it says, the type 2 diabetics are at increased risk for fatty liver and scarring, and it is cost-effective to screen them. Of course, money is not important in patients' health, but governments, if I come and tell them I need to screen all the diabetics, they ask me if this will help the system and will not break the economy, and it doesn't. We found out it doesn't. Why risk factors, metabolic risk factors are important? Because the two risk factors, the more risk factors for metabolic syndrome, for instance, if you have high blood pressure and cholesterol, you are 1.8-fold higher to have fatty liver. If you add to high blood pressure and cholesterol, type 2 diabetes, you're at 2.57-fold higher. And this is what I started showing you, the clinical pathway, where you start with a simple blood test, but I don't want to go too deep in this, but beyond finding the scarring, there are multiple tests that we can do to look for those that they have both NASH and fibrosis in the hepatology clinic. What you need to know is this simple score called FIB4, that is just blood test and age. You put it in a formula, the doctors, someone just can ask his doctor, what is my FIB4? I'm type 2 diabetics. And the doctor will tell you if you have the risk for fatty liver or not based on his calculator. There are also imaging technique. For instance, this is ultrasound-like machine called FibroScan that quantify the fat and the scarring in the liver importantly. There are other blood tests that they can do that. So we have now basket of options, including ultrasound, blood test, and MRI techniques. They are super accurate, can tell me exactly how much fat and exactly how much scarring the patients have. I think I'm gonna, for the sake of time and complexity, to skip all these tests, but I'm going through the slides showing you how many options we have. Indeed, these options can also, without doing liver biopsy, we can monitor non-invasively the disease progression over time. And here we show you figures over time showing you improvement or not improvement of the disease. So I talked about too many tests. I don't want to confuse you. This is the gist of it. If you have patients with type 2 diabetes or metabolic syndrome, you do this test called FIB4. And beyond that, in the hepatology clinic, we do fibroscan, we do MRI techniques, and we start treating patients at risk, and we follow them every 6 months, and we do reassessment, as I'm showing you. With that, I'll stop here, and I'll pass it to Dr. Al-Khoury, who I wasn't sure who was going to introduce him. Farah.
Dr. Mitsunikos is going to introduce Dr. Al-Khoury.
Yes. 1 second, please. Okay. Thank you, Dr. Nureddin. I think you highlight a lot of what we face as hepatologists is that there are a lot of different options. And I think from a pediatric hepatologist standpoint that, we do utilize a lot of those techniques that you mentioned, but some of these other FIB4 scoring systems are not as widely utilized because they weren't validated in children. But I feel like that process will have to change to avoid having to poke everybody all the time, as you said, for liver biopsies. So thank you again. It was a wonderful, wonderful discussion. Next, I would like to introduce our second presenter, Dr. Al-Khoury. He's the Vice President of Academic Affairs and Chief of Transplant Hepatology and the Director of the Fatty Liver Program at Arizona Liver Health in Phoenix, Arizona. Prior to joining Arizona Liver Health, Dr. Al-Khoury served as the Director of the Metabolic Health Center at the Texas Liver Institute and Associate Professor of Medicine and Pediatrics at the University of Texas Health in San Antonio, Texas. Dr. Al-Khoury completed his gastroenterology and transplant hepatology training at the renowned Cleveland Clinic in Cleveland, Ohio, where he was also appointed Assistant Professor of Medicine and Director of the Metabolic Liver Disease Clinic at the Cleveland Clinic Digestive Disease and Surgery Institute. Dr. Al-Khoury is a key opinion leader in the field of NASH therapeutics and an advisor and consultant to many pharmaceutical and biomarker development companies. He is the principal investigator on several multi-center global NASH trials and a member of the NAFLD-NASH Special Interest Group as well. Dr. Al-Khoury's specialty interests not only include non-alcoholic fatty liver disease, but metabolic liver diseases, viral hepatitis, autoimmune hepatitis, alpha-1 antitrypsin deficiency, and liver transplantation. Dr. Al-Khoury, we're ready to hear.
Okay, can you guys hear me okay? Thank you so much for the kind introduction. That was really very kind of you. Let me just share my screen. Okay. So my task for today is to tell you guys about how we manage non-alcoholic fatty liver disease today and also in the near future, because we have very exciting developments and we will have FDA approved drugs in the next few years. So when we talk about the management, we have different goals. For fatty liver disease, obviously, it's a complication of obesity, type 2 diabetes. So number one, we want to induce weight loss, and that will help with fatty liver and decrease liver inflammation and even fibrosis. We also want to treat the metabolic complications, including diabetes, high triglycerides, high blood pressure. We also want to treat the liver itself and induce NASH resolution and lead to fibrosis regression. And eventually what we want to accomplish is decrease mortality from liver disease, from cirrhosis, as Dr. Nureddin mentioned earlier, but also from cardiovascular disease, because patients with fatty liver die from cardiovascular disease, myocardial infarction, strokes, and this is very important to decrease mortality from this. So weight loss through lifestyle modifications actually works wonderfully in patients with fatty liver disease. If you achieve 10% total weight loss, which means, if the patient is at 200 pounds, we're talking about losing 20 pounds, which is achievable. You can achieve fibrosis regression and NASH resolution in a good percentage of patients. The issue that we face in our clinics every day is that only a minority of patients, less than 10%, are able to lose that amount of weight and sustain it. And this is due to the fact that weight loss is really difficult. It's probably the most difficult thing you can try to do because, nature doesn't want us to lose weight or restrict our calories. Usually, in the animal kingdom, you have food, you eat as much as you can because you don't know if you're going to have a meal for a few days. So, the concept of weight loss is a new concept. The fact that we talk about it now is really, again, biologically an interesting concept, but it's very important. It's hard. So if we can't lose weight with lifestyle, can we do surgery, bariatric surgery, whether it's the sleeve gastrectomy or the Roux-en-Y? And if you do that, you lose a lot of weight, but also you help your liver tremendously. So in this study done in France, where they followed people for 5 years after surgery, they showed that 85% had NASH resolution. And then there was a good percentage of patients that had fibrosis regression. And the more weight you lost, the more likely to have NASH resolution. So if the patient is willing and able to undergo bariatric surgery, that's a nice solution for fatty liver disease. This is a study that we published last year in a journal called JAMA, looking at long-term outcomes from bariatric surgery in patients with fatty liver disease, looking at their cardiac outcomes and liver outcomes. And what we showed that after we followed them for 10 years or so, that there was significant reduction in the cardiovascular outcomes in the bariatric surgery group compared to a control group of patients with fatty liver disease who did not have the surgery. And more relevant also in terms of liver outcomes, there was significant reduction in what we call major adverse liver outcomes, MALO. This means that they developed less ascites, fluid in the abdomen, less encephalopathy, confusion from liver disease, bleeding from varices, or needing liver transplantation. So bariatric surgery is definitely an effective way to treat fatty liver disease. The problem is that only 2-3% of patients with fatty liver disease will end up undergoing bariatric surgery. So I mentioned that lifestyle modifications are wonderful, but they are not effective because people don't lose weight with this approach. Bariatric surgery is wonderful, but it's not widely utilized. So we need something in between. And this is when we consider what we call anti-obesity medications. So we have several medicines to help people lose weight. This is a list of these medications that are approved in the United States. And if you have fatty liver disease, you should talk to your doctor about getting a prescription for weight loss medicine. The first 4 medications are pills. They do have side effects and the weight loss is not that great. The last 2 medicines, especially the last one, semaglutide, this is an injection you do once a week and it's been associated with significant weight loss. In fact, this is the data on semaglutide from a large study called the STEP 1 study, showing that after a year or so of using semaglutide, on average, patients lost 17% of their total body weight. So if you're 200 pounds, you're talking about almost 35-pound weight loss. What's important also to notice that, when you try to achieve that 10% total body weight loss, about 70% are able to achieve this with semaglutide compared to only about 10% in the control group. So semaglutide with the name Wegovy is probably the most effective weight loss drug we have on the market today. And this is a diabetes drug. It helps with cholesterol levels and it will help with fatty liver disease. And it has an FDA approved indication for obesity and for type 2 diabetes. Another area is what we call prescription digital therapeutics. This is a hot area in medicine these days. These are apps that you can have on your smartphone, and they need to be prescribed by a physician, and they provide support in terms of lifestyle interventions. So you get cognitive behavioral therapy, explanations about why we overeat and how to combat overeating. They provide you with recipes that are healthy and exercises. And you can also communicate with a dietitian or an exercise physiologist or psychologist. So more to come on this, but these apps will be prescribed by a physician. They should be covered by insurance, and they will help us induce more sustainable weight loss. So when we talk about weight loss in patients with NAFLD, there's really a spectrum of things we can do. We should always start with lifestyle interventions, but then we can move on to digital therapeutics, weight loss apps. We can use anti-obesity medications. We also have new procedures. We call them endobariatrics, where you can put a stomach and well, you can put a balloon in the stomach, or you can suture the stomach endoscopically. And this is kind of like a bridge before bariatric surgery. And then, as I mentioned, bariatric surgery is a very effective way to induce weight loss. So there are many ways to lose weight in patients with NAFLD. We also have some medicines that can help the liver directly without inducing weight loss, including pioglitazone, which is an older diabetes medicine, and vitamin E, which is an antioxidant. So we have a study that was published 12 years ago showing potentially benefits of pioglitazone and vitamin E. And this study, they showed that there was higher rates of NASH resolution with pioglitazone, and there was a trend showing efficacy with vitamin E. But it's important to realize that these medicines have side effects. Even vitamin E may potentially increase the risk of hemorrhagic stroke and prostate cancer. Pioglitazone causes weight gain. It moves the fat out of the liver, but into the subcutaneous under the skin fat tissue, and there's potentially increased fluid retention, worsening heart failure, and other side effects. Liraglutide is a medicine that you do as an injection. It's a diabetes medicine that's been shown in one study to improve NASH and induce weight loss and decrease in liver enzymes. And these are the AASLD guidelines. This is the American Association for the Study of Liver Disease, and they basically recommend pioglitazone and then vitamin E. And they say that other diabetes medicines like metformin are not indicated for NASH. Same thing with liraglutide, but more to come on liraglutide and similar medications, and they might be indicated for NASH in the future. The last few slides, I want to just tell you about a few drugs that are in the pipeline to treat NASH and liver fibrosis. And once these are approved, they're going to change how we approach this disease fundamentally. So the FDA established a pathway for drugs to be approved. To get to FDA approval, you need to have a safe drug that can lead to one of two endpoints. Either you need to have a resolution of NASH, the aggressive form of NAFLD, so you need to have minimal liver inflammation and no evidence of liver cell injury on a biopsy, or you can show that you induce fibrosis regression. So if someone, we have 4 stages of fibrosis. So if someone starts with stage 3, and then you treat them for a year or 2, and now they have stage 2, this is what we call fibrosis regression. Now, obviously, we can do liver biopsies on many patients, so we try to find non-invasive tests that can predict NASH resolution and fibrosis regression. So we have special kinds of MRI PDFF that can quantify liver fat. We look at liver enzymes, ALT, AST, and then we have several imaging tests that can measure the fibrosis stage, and we are trying to establish what is the threshold of improvement that will predict fibrosis regression by 1 stage. When we think about all the therapeutic targets, this is a busy slide, but basically we have 3 major categories of fatty liver drugs. The first category is what we call metabolic drugs. These are drugs that work on your metabolism. They may help you lose weight or improve insulin resistance. They may block the enzymes that make fat inside the liver cells. The second category is drugs that work on decreasing liver inflammation and cell death. And then the last category is what we call anti-fibrotic drugs. So they target that scar fibrosis tissue. This is the pipeline of all the drugs we have. It's a very busy pipeline, which is good for patients. And we have several drugs now in what we call phase 3 clinical trials, which means that if the trial shows no safety issues and the drug is effective, leads to NASH resolution or fibrosis regression, then they will potentially be approved by the FDA. So here I'm listing the 4 drugs in phase 3 trials. Over the next few slides, I'm just going to give you a very quick overview of how they work. So one of the most advanced drugs that might be approved as early as mid next year is called resmetirom. This works on your thyroid hormone, so it mimics the effects of the thyroid hormone without the side effects that you may get if you just basically take pills with thyroid hormones. So very selective drug for the liver. And in one study, it showed that it can decrease liver fat very quickly within 12 weeks. And then in selected patients that had liver biopsy, they had NASH resolution with this medicine. So very promising drug. The second drug is called lanifibranor. It works on what we call nuclear receptors. So these are receptors inside the nucleus of the cell. They sense fatty acids and they modulate your metabolism. So I don't want to get too deep into the mechanism of action, but this is basically a pill that can affect how you metabolize fat in your body. And in one study, it showed that it can lead to NASH resolution in 45% of patients after only 6 months of treatment. And there was also fibrosis regression in about 40%, and about 30% had both NASH resolution and fibrosis improvement. The third drug is the one I mentioned earlier for weight loss, semaglutide. This is the weekly injection. And we had one study that looked at different doses with semaglutide. And if you look at the high dose semaglutide, about 60% of patients had NASH resolution after 72 weeks. So very promising. This is a great drug because it makes you lose weight. As I mentioned, it improves insulin sensitivity, dyslipidemia, and now we have evidence it might be beneficial for NASH. The last drug I want to mention is called obeticholic acid. This is a bile acid that we make in the lab, and it modulates how we produce bile acids in our body. And it's been tested in a large study called the Regenerate study, where we had 2 doses of this medicine, obeticholic acid and placebo. And they showed that there was actually improvement in fibrosis in 23% of patients that were treated with the high dose. So this is promising. The issue is this drug causes itching, pruritus, and it may worsen your lipid panel, and it can cause cholecystitis, so gallbladder issues, and potentially hepatotoxicity. So it's not FDA approved. So when we think about the new drugs, and hopefully we will have a few to choose from in the next few years, we need to think about how they affect the liver, what is the rate of NASH resolution, fibrosis improvement, reduction in liver fat, liver enzymes. But we should also think about how they affect what we call the metabolic syndrome. So do they make you lose weight? Do they improve your lipids and insulin sensitivity? And this is very important in this patient population. And then we should be familiar with their adverse events. Each drug has a list of adverse events, and based on these, sometimes it's not appropriate for selected patients. And here we're showing how we can compare these drugs that I mentioned in phase 3 in terms of their effects on the liver, metabolic syndrome, and side effects. So this is my last slide and take-home message. Weight loss remains really the mainstay of NAFLD management today, but don't accept your doctor telling you, okay, well, you need to lose weight, eat healthy, and come back in 6 months, and I want to see you lose 20 pounds. That's easier said than done. If that was just so easy to do, you would never see an obese doctor and nurse, because they're in healthcare and they know what to do. So easier said than done. I tell my patients I've been trying to lose 10 pounds for the last 10 years and I'm still struggling with it. So ask about anti-obesity medicines. Ask about digital therapeutics. There are some that you don't need a prescription, like the Noom weight loss app. Ask about bariatric surgery and endobariatric procedures. But if we cannot induce weight loss, then we have new drugs that will be hopefully FDA approved in the next few years. And this is why it's so important to screen for NAFLD in high-risk patients like those with type 2 diabetes, identify high-risk patients that need pharmacologic treatment, and then as soon as we have these drugs, we can get them started. And in my practice, we are warehousing some patients and telling them that, okay, although today we don't have much to offer you. As soon as we have drugs approved on the market, we will prescribe them for you. Myself, Dr. Nuruddin, many places in Texas, Arizona, California, we offer clinical trials for NASH, and this may provide selected patients with access to these drugs that are still considered experimental, but they're very advanced, and that means that we have a lot of safety and efficacy data. We just need to get to the finish line and get them FDA approved. So also consider asking about the clinical trial availability for patients with NASH. And finally, I lived in Texas for 3 years, so this is the food pyramid in Texas. We start with pecan pie all the way to steak, and that's why it's so hard to lose weight. So we need to change the way we eat and the way we think about food. But again, as I said, easier said than done. So we need every piece of help we can get from our doctors. Thank you so much for your attention.
Thank you, Dr. Al-Khoury. That was a wonderful presentation, and again, highlights, I think, that the theme tonight about NAFLD and NASH is that it's a highly complex disease that's influenced by many other conditions. Type 2 diabetes is really kind of a common denominator in a lot of both your discussion as well as Dr. Nuruddin's. I just wanted to start just by asking kind of your thoughts on the influence of type 2 diabetes in these patients, given that such a high proportion of them develop fatty liver disease. And, we see the same trend in pediatrics as well. How do you think that plays a role? Is it separate? Is it a separate pathophysiologic process? Compared to what we understand and know about the pathophysiology of NAFLD and its therapeutics in its current state?
I would say, type 2 diabetes and NAFLD are really, very interconnected. So in patients with type 2 diabetes, we said in the general population, about 25% have NAFLD. If you have type 2 diabetes, 60% have NAFLD. And then the prevalence of NASH is higher if you have type 2 diabetes, and the prevalence of advanced fibrosis is higher. So type 2 diabetes makes your NASH worse, but also NASH can precede type 2 diabetes, but once you have NASH, you are twice as likely to develop type 2 diabetes. If you look at patients with NAFLD-NASH that we see in our clinic, 45% have type 2 diabetes, as opposed to about 10% of the general population. So we always say that NAFLD is the hepatic manifestation of diabetes and metabolic syndrome, but they're very interconnected. And we see similar trends in pediatric patients, although the rates are lower. So we estimate NAFLD is about 10% of children. Many of these children have prediabetes, but the prevalence of diabetes, type 2 diabetes in children with NAFLD is between 5 to 10%.
Dr. Coley is online and he's asking a question. He's saying, which one of these medications under study would you be open to trial in pediatrics?
I'm involved in some pediatric study design just because I trained in MedPed. So as you guys know, when you get to a phase 3 trial, you have to submit something we call the pediatric study plan. This is required by the FDA. So all of these companies are looking at this, and I think, there is no clear plan, but there are, some initial thinking with resmetirom, for example, with lanifibranor, I'm sure with semaglutide as well, and with obeticholic acid. So I would say all of these drugs are potentially something to be studied in pediatrics. But I think, again, there are no announcements today that they're getting into pediatric trials. We had actually some companies in the past look into studying pediatric NAFLD before they even moved into adult NAFLD. And there are some more like supplements, modified amino acids and modified fatty acids that are being considered to be studied in pediatric population as well.
We have a couple more questions, Dr. Mitsiniakos. I'm going to read them and then we can go back to the questions that you had received. This question is from one of the nurses at UCLA, Erika Der Sarkisian. She's asking for Dr. Alkhouri, for patients who successfully lose weight with semaglutide, I want to say, are they able to maintain their weight loss in the long term after discontinuing the drug?
That's an excellent question. So, the initial study that was designed with semaglutide for obesity was called the STEP 1 study. They included about 2,000 patients in that study. And after 68 weeks, they lost 17% of their total body weight. But then they had an extension of that study where they followed close to 400 patients over another year when they stopped the semaglutide. And unfortunately, 1 year later, they regained 2/3 of that weight that they lost. So, it seems like there's weight regain if you stop semaglutide. Now, everyone wants to treat obesity quickly and be done with it and have this sustained weight loss. But the thinking now is that obesity is like type 2 diabetes. We don't treat diabetes for a year or two and then stop. We keep them on medicine. Most of the patients with type 2 diabetes will be on medicine for life. So we need to think about obesity in a similar fashion. I'm not saying that, we should just blindly keep them on the same medicine for life. But I think, if we stop the medicine, we need to monitor quickly and we need to restart the medicine if we start seeing signs of weight regain. And potentially some patients have to stay on it. But if you stop it after 1 year, weight regain is common.
Another question is, in primary care, does an elevated C-reactive protein suggest NASH in a patient with a BMI of 27?
CRP is not a specific test for NASH. Of course, you have to follow up on abnormal tests, but it's not being used as a way to distinguish from NASH versus not, or NASH with fibrosis versus not.
Thank you. Dr. Mitsiniakos, we'll come back to you with the questions you have.
Sure. These were a few questions that we had received prior to the start of both of your presentations at the time of registration. I'm going to kind of group a few of them together. And this may be a question for Dr. Nureddin, specifically about which individuals outside of those with metabolic syndrome and type 2 diabetes would be at risk. Are there ethnic groups, gender predispositions? Could you perhaps comment on that?
Yeah, there are a lot of people that we want to pay attention to. There are genetics components. The genetics components suggest that Hispanic population are increased risk for NAFLD and NASH, especially if they have a certain genotype. There are other conditions associated with higher risk of NASH and NAFLD. For instance, the HIV population, they are prone to that. There are some endocrinology diseases, such as lipodystrophy, which is abnormal distribution of fat on the body. You see it in women with polycystic ovary syndrome. You see it with hypothyroidism and hyperthyroidism, but also there's a unique subpopulation, which we call it lean NAFLD, that very common in Asian population. Usually they have sometimes metabolic syndrome, but they might not. So we pay attention to these, but looking at the highest risk and the top of the disease spectrum and who we really should go effectively after screening are the diabetics and people with risk of metabolic syndrome. But it's a great question. That doesn't mean we should leave people out and not pay attention to them.
Yes, absolutely. For maybe some of the non-health professionals in the audience tonight, could either of you comment on symptoms that may develop? It may have not been as clear during the discussion for what symptoms may develop in disease progression of NASH, and probably more specifically to symptoms of or signs and symptoms of cirrhosis.
I can go. So once we'll go back to George when they called me that he has increase in his abdomen circumflex, which that means usually a fluid accumulation in the abdomen called ascites. They also can turn yellow, jaundiced, and this is usually bilirubin of 3 and higher. They might get confused, which call it encephalopathy. They might get tired, which is throughout the spectrum of the disease, not just cirrhosis, but in general, the signs I mentioned are in advanced liver disease, and sometimes they vomit blood in what we call variceal bleed. So there is a spectrum of symptoms with the cirrhosis. The goal is to avoid it when people think they are asymptomatic and they still have the disease. And I say they think they are asymptomatic. This is before cirrhosis, because we found also like they get the symptoms that all of us have every day. I'm tired, I cannot get up. Sometimes they get this dull pain on the right side of the body, and they think it's probably food. So pay attention especially if you have risk factors.
Absolutely. I agree. It's a little tricky when you have these vague symptoms, and when you start developing these more severe symptoms, it's a little too late. So yes, it is important to bring this up with your doctor, and if something doesn't feel right, to really kind of really have the discussion and kind of look into it in a little bit more detail. I had a question about the utility of FibroScan, and more so in kind of looking a little bit backwards. I know we've been talking about identifying those with advanced fibrosis and trying to identify that group that will benefit from some of these pharmacotherapies as well as bariatric surgery. But my pediatric mind will always think, what can we do earlier? How can we prevent some of these metabolic syndrome developments, weight gain that we're seeing, the obesity crisis that we're seeing really probably worldwide? And there was actually a podcast I listened to. Dr. Al-Khoury was talking to, I forgot the host name. It was on the Ride the NASH Tsunami podcast. But I think what really struck me from the discussion on that particular episode was using FibroScan and not using the KPA measurement, but using the CAP score and identifying degree of steatosis, of fat in the liver, and perhaps using that at an earlier stage and identifying those who might have earlier or higher grades of steatosis, and having more rigorous interventions at an earlier age. I'm just curious to hear what you think about using that type of measure, really more as kind of added data to kind of help patients understand that this could develop into something, and we have the opportunity to do something about it before it even becomes a problem.
Yeah, I mean, I couldn't agree more that, age is very important in every decision we make in medicine. Having fatty liver at the age of 80 with no fibrosis is a benign disease, but having fatty liver at the age of 10, even without fibrosis, is just not good for you. And we have data now emerging from Sweden, for example, where they followed patients over 30 years, showing that these adolescents with fatty liver disease are more likely to die from heart disease and develop cirrhosis. So I think, the earlier you identify fatty liver disease, especially if the intervention is really a lifestyle intervention that targets healthy eating and being more physically active, there is no downside to this. Obviously, we don't want to use expensive medications or, bariatric procedures and people with fatty liver without evidence of fibrosis, because that's not the right thing to do. But if the intervention is a lifestyle intervention, I think that's fair. The CAP score is a good way to identify fatty liver, but I caution you that it's not a good way to monitor, the exact amount of fat and if you're responding to a lifestyle intervention. So I like it as a screening tool, as you said. But just take it with a grain of salt when it comes to the amount of fat and monitoring disease progression or regression. I always tell my patients with fatty liver disease, again, I don't want you to be terrified with this. Think of this as having high cholesterol. If you don't do anything about your cholesterol, over many years, you may end up with a heart attack. If you act on it now, then nothing will happen. And my job is to make sure that nothing happens. But yeah, I agree. In younger kids, you can utilize these tools to screen, implement lifestyle interventions, and completely reverse this process. So I encourage it.
Thank you. Yeah, we certainly use FibroScan a lot at CHLA, and not just for NASH and NAFLD, but for all liver disease conditions, and even in post-transplant patients as well in certain cases. Again, it's more looking at trends rather than absolute numbers, perhaps in some of these conditions, because they may not fit the cutoffs and criteria may not really be equivalent, but I think it's a really valuable tool. It's so quick and easy to do and gives you, as a hepatologist and the patient, so much valuable information to make some clinical decisions, or at least a very educated guess at where they're at.
So let me give you a challenge, since I have you and I see Dr. Coley is also on this webinar. One of the biggest issues we've had with FibroScan, it's low positive predictive value, especially in younger patients. So you have an adolescent, you do the KPA, you get a value of 11, and you're scratching your head, do they have F3 or not? And often it's not. And you guys do some biopsies and you have a large cohort. And recently they developed new scores in adults called the FAST score, Agile 3+, Agile 4. And there's really no data in adolescents. So help us out and maybe test these scores in your younger patients. And let's see if we need to maybe change the cutoffs, or maybe you can come up with your own score. But this has been one of my biggest frustrations in younger adults, is the overestimation with fibrosis stage. And we do need some help.
Yeah, I would agree. I mean, there's, we talk about the FIB-4 score and all of this and these cutoffs, which are really helpful thresholds to use to kind of stratify your patients, to really identify those who need certain interventions. But we just don't utilize that and don't have that in pediatrics. So it's been something that I've been thinking a lot of, and especially with this FIB-4 score in particular. I don't know that I can create a new one, but we certainly can start looking into this data and seeing the correlation, because you're right. We do use a lot of liver biopsy in the pediatric population. We don't really treat any patient with NASH unless it's biopsy proven. We will say you've got NAFLD, but we don't know on what spectrum that they really are. And sure, we can use the FibroScan, but truly, if you look at the NASPGHAN guidelines, the gold standard is still liver biopsy. And there's different considerations in pediatrics, like other metabolic diseases that could mimic fatty liver disease. So there's that to consider, and understanding the utility of the liver biopsy. But it's finding that threshold, who's really at risk, who do I really need to do this biopsy for? Because it's not without significant risk. It's generally not high risk, but nonetheless, it's an anesthesia. It's an invasive procedure.
I have a question from Dr. Coley. It's there is a certain level of discussion on the nosology of NAFLD-NASH. Would either of you comment, please? Dr. Nuruddin, Dr. Alkhouri.
I think we were talking about the whole NAFLD versus MAFLD. Is that the question?
Maybe I'm not pronouncing it. Discussion on nosology, N-O-S-O-L-O-G-Y, of NAFLD-NASH.
Yeah, what Dr. Corey mentioned is there's a debate on the name that I will leave it up to end of July. We'll come back to you. If there is a consensus conference that is gonna happen in July 8 and 9 that is gonna be international, and we'll keep you guys posted.
And another question is, can you mention, and I'm gonna stumble over all this name, Helioliver and an NGS circulating DNA blood test to detect liver cancer?
Yeah, I mean, in patients with NASH and cirrhosis, they have increased risk of hepatocellular carcinoma, liver cancer. So routinely we do a liver ultrasound, and we do a blood test called alpha-fetoprotein, which has some limitations. So there are newer tests now that are being developed and validated to screen for liver cancer, including the Helio liver test. They look at newer biomarkers, including some genetic sequencing, looking at circulating DNA. So these are up and coming. I think they're going to make it to the standard of care guidelines. There's more data that's being generated now. But I think the key message is, if you have NASH with cirrhosis or even advanced fibrosis, that you should be considered for screening for liver cancer, and you need imaging plus minus blood tests. And the imaging sometimes, with ultrasound is not the best way in patients with NASH because of obesity. So sometimes as doctors, we alternate with MRI or CT scan. I prefer MRI more just because there's no radiation involved, but that can be more costly sometimes.
And the question Dr. Coley continues to ask is an appropriate use of alcohol in terms for children, since it's non-alcoholic children's.
Yeah, I couldn't agree more with Dr. Coley that, the name has a problem, especially in children, adolescents. When I'm sitting with a, 13-year-old and telling them you have non-alcoholic fatty liver disease, they look at you like, are you stupid? Like, well, you think I'm drinking alcohol and you're telling me it's non-alcoholic. So I don't even use that terminology with adolescents. I say you have fatty liver disease. Now, I mean, there is a suggestion that we should move away from this terminology to calling it metabolic fatty liver disease, or MAFLD instead of NAFLD. Some people are suggesting, why don't we call it nutrition-associated fatty liver disease and keep the same abbreviation with NAFLD? So this has created, a big debate, and we have a whole conference dedicated to it. This is what Dr. Noureddin was talking about. I do believe we need a change in the name, especially in adolescents, and we need to take the word alcohol out of the terminology. I couldn't agree more. The issue is, Farah, as you know, we had an issue with awareness of this disease, and now we're getting some traction and people are knowing what NAFLD is, what NASH is. We don't want to confuse the public and now have a new thing called MAFLD. And then what do you call NASH? Is it MASH now, or do we keep NASH? You have the FDA, you have drug developers. So that's why the hesitation is there not to change the name completely. We've done a name change for another liver disease called PBC, primary biliary. We used to call it cirrhosis, which was wrong. So we changed it to primary biliary cholangitis, but the abbreviation stayed the same as PBC. And my gut feeling is that we should try to do the same for NAFLD.
I would agree with you. I've had others bring up criticisms with the names, but not looking at the alcoholic piece, but the fatty piece. And talking with adolescents and younger children, it's sometimes you want to also be careful about your lifestyle advice giving and weight loss and how much weight to lose. Because I've seen other ends of the spectrum where they will stop eating entirely, or they'll only eat one meal a day, and they really get into disordered eating habits and run the risk of developing eating disorders. So and both of these ends of the spectrum carry their own health risks. So it's hard to take away the fatty part, because it is fat in the liver, and that is one of the main driving forces to this disease. So it's a little bit of a tricky situation. And you know, our clinic is called the Fatty Liver Clinic, but that's exactly what we're treating is fatty liver disease. And I agree with you. I don't use the non-alcoholic portion when I explain it to patients. They're like, what? Well, I don't drink beer. I don't know what beer is. You know, talking to an 8-year-old, they're a little very naive, and their innocence is precious, but they don't understand it.
Yeah, I agree. I mean, I've seen that look, especially on the face of teenage girls when you say a fatty liver disease, they cringe, and you know, you don't want to push them the other extreme. And you know, the whole obesity discussion also. I mean, these words have a heavy sound to them, you know. And unfortunately, you know, I see adolescents with severe obesity, BMI above 99%, and for the family, they say, okay, I realize they're slightly overweight. This is what, you know, how they say it. It's a very sensitive topic, and I agree. We need to find a way to kind of like destigmatize these words. You know, obesity is not, it's a medical condition, and maybe we need to come up with a new name or just educate the public that when we say obesity, it indicates potential for health problems. We're not, you know, talking about looks or BMI as an absolute value, or, you know, and I think this is one of the issues we have when we call it fatty liver. There is literally fat inside the liver cells, but I mean, can we call it steatosis? I guess we could.
There is a longer question, Dr. Mitsinukis, that I emailed it to you.
Oh, okay. Give me 1 second. Let me bring that up.
Well, I must say this is lovely, the interaction and all the questions. So thank you guys, all the attendees.
That is the
Farah,
part of,
I
yes.
think this is the same question that was in the chat box already. Oh, hold on. Yeah, it's the same question about that Helio liver test that you had already brought up. It's a little bit of a longer description. I think it's the description of the test, but I think Dr. Al-Khoury had already addressed that.
All right.
So again, these tests are trying to kind of answer the limitations of just your typical alpha fetoprotein. And I think, you know, they look promising, but we need more data before they are part of the guidelines and before they become standard of care.
Yes. Well, thank you very much. This was a wonderful presentation. I loved the conversation we had with our between our doctors. That's a part of the information that our audience really love, when the doctors talk to each other and bring up issues that they are very interested in. Dr. Nuruddin apologized for not being able to stay online because it's 8:39 in Texas. He needs to help with the kids, put them to bed. So we understand. I want to thank Dr. Al-Khoury, Dr. Nuruddin, and Dr. Mitsinukis for their attendance. We really appreciate your time. We know you're very busy, and this is very important for our patients, and I appreciate your participation. We also want to thank Exelixis for their continued support of Liver Health Foundation, as well as Merck for their grant that made this webinar possible. And just a couple of short notes about what's coming up. Next month in July, we'll have a webinar on drug, alcohol, and your liver, which really fits very well with what we just talked about. So to register, please visit liverhealthfoundations.org/program. And I'm very happy to announce that we will have 3 in-person events coming up later this year. We have a Walk for Your Liver in Los Angeles on 18th of September in Santa Monica, right on the beach. We have Salute to Excellence Dinner Gala, during which we honor some of the best of our hepatologists in LA and other areas. That one is on September 30th at the Tapleon Cultural Complex in Hollywood, where we have been holding our events for the past 5 years. And Walk for Your Liver in Orange County, October 16 at William R. Mason Regional Park in Irvine. So please mark your calendars. We'd love to have you with us. We are also on social media. Please visit our social media sites and like us. We'd like for you to like us, please. Thank you for attending this webinar again, and please stay safe. Before I go to announcement, this weekend is Father's Day, so happy Father's Day to all parents, all fathers and brothers and grandparents and all the men who have ever taken care of any kids. And also our IT person, Laurie, is getting married this month. So Laurie, congratulations on your wedding. We can't wait for you to come back from your honeymoon and come back to us again. So again, thank you for attending this webinar. Please stay safe and healthy, and we'll see you next month in July in our next webinar. Good night.